Hey guys, so that was part one with Omid talking pre-dent and the journey that he took, and then we kind of just got cut off right at the end there, and we were talking about just if you see something which is, as shocking as the things that we've seen recently on social media, you have to, you need to be saying something about it and, bringing awareness and doing whatever you can to help in those situations. Second part of today, we have got David Alleman. We are going to be talking a little bit of biomimetic dentistry, and also kind of a bit about his journey as well. So complete change in direction. It's going to be a bit more clinical this time. So Davey's actually here. So into the comments. Who's in the house here? Loads of people joined us okay already. For us here again. Hey man.
How are you doing?
Good, thank you. How are you?
I'm doing great.
So yeah, we've just had part one. We had dental student on talking about pre-dent, and now we've got you yourself. You're obviously a qualified dentist. How long have you been working, man?
I graduated in 2015, so going on almost 5 years.
Nice. So you've obviously done quite a lot of work in that time, and you've brought your level up to, especially your photography levels. It's kind of really interesting now. You're doing before, middle, after, so guys can see kind of the whole process of how your work goes. When did you start doing that, and kind of what was the thought process?
The thought process was I was in the Army. They paid for my dental school, and I was getting a lot of flack from some of my superiors about, what I was doing as a clinician, and I thought that was a little unprofessional considering my interpretation and understanding of the science. And so I started to document my cases because I knew that my work was at least to the same standard as, my peers, if not much. I don't know how to say it right, but superior. And so, I started taking pictures just with my phone, and it just kind of gave me, a little bit of a defense mechanism that if somebody ever called me out on what were you thinking here, and I can say, this is what happened. This was the good things I did. This was the things I could have improved upon. And, I'm just out of dental school. I'm trying to get better. And so it's just kind of evolved into something that allows me to be honest with my work. And so I'm not ashamed to show a picture with a ripped rubber dam or a little bit of blood on a prep after I take a dam off. And I don't believe in showing fake dentistry. I want to show what I'm doing just on a daily basis, and to show all of my work, not just the highlights.
Yeah. Where did you do your training?
So I did my training at Roseman University of Health Sciences. I was in the first graduating class. It's in Salt Lake City, Utah. There was some interesting challenges with being the first class, but I grew up literally like 2 miles from where the school was, and so the benefits of staying close to home and just outweighed some of the cons of a new school. But also there's some flexibility that new schools aren't as set in their ways as some of the more
traditional
established schools. And
yeah,
I would have liked them to be a little bit more progressive in their approach, but to be honest, I just don't. At the end of the day, it's just getting a piece of paper, and then you have to figure out how you're going to practice the rest of your life.
Yeah, and then make your own kind of name for yourself afterwards, because like you've done, you've taken all the photography and things to another level, so you've shown what you're capable of. So what does it matter where you kind of went, when you can show the level of treatment that you're doing and how you're going about things? So I think that makes sense. How did you fall into, I suppose we would call it biomimetics, that you're kind of into at the moment, aren't you? So where did you kind of start along that journey?
So I was kind of born into it. That's the thing. So my dad's a practicing dentist. He's been practicing for 43 years. And about the time when I was like 8 to 13, my dad really hated dentistry. He was like ready to quit, wanted to become a history teacher. He was just frustrated with all the problems and failures that traditional dentistry presented. And he started to get introduced to adhesive dentistry and some of the basic concepts that allow a tooth to be restored in a much more conservative manner. And you could see that the potential benefits would solve some of the issues that he was having in with how he was trained at the University of Pacific back in '79.
Yeah.
And my dad, he's a bona fide genius. He's brilliant. He's got a photographic memory, and he has a way to internalize very difficult reading and make it into a learnable approach. And so he's been training doctors since 2004 in tooth conserving and biomimetic dentistry. And as soon as I saw the light bulb go on how excited he was in fixing teeth, it made me want to become a dentist. So he spoke to my 7th grade careers class, and I decided at that moment in Miss LaFlame's class that I was going to be a dentist. And
here we are.
Now, I guess 20 years later, I'm a dentist now, and doing a lot of the things that...
It's okay, I was kind of hinting towards that with the question. I think you kind of knew, didn't you? What would you say the principles that he kind of, in a way, pioneered? Obviously, there's guys like Pascal Magna out there, and I can't remember the other guy's name. It's just dropped out of my head. But
Didier Dici, Simone Della Peri, Gary Underbrink, they were all key players in the advancing of moving away from traditional retentive preparations such as full coverage crowns and going along a more adhesive approach. Yeah. And so what my dad did, he wasn't ever affiliated with a dental school. So there are people that do research and teach, and there are people that do private practice and teach, but you can't do all three. You can't do private practice, research, and teach. And so, my dad's specialty really was interpreting the literature, and how he interpreted the literature really pioneered the concept of a peripheral seal zone and a caries removal endpoint and how it relates to the hierarchy of bondability, so you can preserve pulp vitality through indirect pulp caps, so you're just never exposing nerves that you don't need to expose by chasing that last little bit of decay or caries. Because if you understand how something bonds and the weaknesses it has, you can engineer for those weaknesses. And the science is very clear that the more direct pulp caps you do, the more inflammation the nerve undergoes and is more likely to have
have we lost Davey there? Are you back? Yeah.
Problems down the road.
Yeah, I think that's kind of key. I've got your Instagram page up behind me, so we'll have a look at a couple of cases in a second. So I think what's really interesting is that idea of a caries endpoint, which isn't the traditional kind of old school method of remove everything, and if you're into the pulp, then deal with it as and when. You guys tend to use a lot of caries dye. How does that work in practice? And obviously I can just say, oh yeah, go and use caries dye. But what are you looking for in...
So caries detecting dye was invented by Takao Fujiyama in 1978. And what it does is it infiltrates and stains where the collagen has either denatured or collapsed. And the degree of pigmentation can be associated with the level of infection. So it doesn't stain bacteria, it stains denatured collagen. So if there was a large amount of destruction through the carious process, then the darker the stain will be. The only caveat is the deeper you go, the size of the lumen of the dental tubule triples, and the concentration also triples, so you can have some light staining that is still technically caries free. But that being said, In Japan, they've actually studied the bond strength of what we would consider sound dentin, which would be no stained, inner caries, which is lightly stained, or as most people refer to it as affected dentin, and then outer caries, which stains dark red and is highly infected. And each of those different dentinal substrates have different bond potentials. And so if you can maximize each of those bond potentials, you can really preserve the vitality of a lot of pulps.
Right. So in that kind of study, are they advocating removing the infected dentin and maybe doing a partial removal of affected, which is the advancing front?
So it has to really deal with how well you understand tooth anatomy and where the pulp is. Because in certain areas you can be very aggressive and you will never hit the nerve. Other areas of the tooth you can take that same approach and you can hit the nerve every time. And so around the perimeter, which is about 1 to 2 millimeters of dentin inside the DEJ, you can never expose a pulp if you have the DEJ as your guiding principle. And so we would want no red, no pink, and what we'd consider sound dentin in those areas, because that will be the area that we will have the highest bond strength.
What I'll do is I'll just switch my camera around so the guys can see what I think is a really nice example of this particular thing. Let's just drop it around here. So this is one of your more recent posts, isn't it?
Yeah, that was a couple weeks ago.
So yeah, you can see this is the area that we're talking about. We can be much more aggressive. We're unlikely to hit. Well, it's impossible to hit the pulp in your interproximal zone.
Exactly.
As we go through the treatment, you start to get a little bit closer in this kind of area. So you may be being a bit more conservative here, aren't you?
Exactly.
So, and then what we're thinking is, as long as we've got this peripheral zone on the outside where we're completely free of the dye, we're caries free, and we can get a seal and stop any of the advancing front having any substrate to work on and advance further.
Not only will we get a seal, but we'll actually get a bond strength that approaches the tensile strength of the DEJ, as long as you allow that bond to mature in a stress free environment.
Yeah.
So
it makes sense when you kind of go through it in a step-by-step method, doesn't it?
It does.
And where does immediate dentin sealing kind of play into this whole idea?
So immediate dentin sealing is the idea that you would seal a preparation before you take your impression. So the traditional approach was to bond at the same time as cementation.
So I think we're getting a couple of connection issues. We'll hopefully have Davey back on soon.
Yeah. The problem is, if you bond at the same time as cementation, is that the polymerization of your cement will be strong enough that the adhesive will shrink towards your restoration and not towards the tooth. And so immediate dentin sealing allows you to seal the dentin and not place any material or a large bulk of material that, as it polymerizes, can move in the opposite direction of the tooth. And so what we want to do is we want the material, as we place it from the bottom up, to stay sealed and stay bonded at the deepest portions of the restoration. And the best way to do that is in a low C factor increment, and the material is dumb. It'll think there's only one direction it can go, and that's the way of the tooth.
Yeah. Can you explain the C factor a little bit, very briefly, because I think it's something that people generally get a little bit confused about when we start dropping kind of that terminology in, especially dentists who are going through dental school, which is a lot of the viewership maybe.
Yeah, so C factor is one of the most studied and foundational principles in adhesive dentistry, And the research back in the 80s by Carol Davidson and his team out in Acta University studied how the movements of these molecules interacted and the stress it caused as the
Yeah.
material goes through a free radical reaction. And so C factor by definition is just the ratio of bonded to unbonded surfaces. So if you think of it as a plate being low C factor, a bowl being medium C factor, and a cup being the highest C factor, it all has to deal with how much free surface as it relates to walls that constrain the material. And so you could have a high C factor prep, but if you use small enough increments, then the free surface is still quite favorable to the actual area that it's being connected to.
Yeah. And how does this C factor influence? Because obviously the old school was to do a full coverage restoration with a high central portion, and you're going to use a crown with a cement. Obviously now with adhesive dentistry, we're trying to be more minimal, prepare much less of the tooth structure away. How can we utilize that C factor principle in that planning of a restoration?
So if you ignore C factor, you will cut your bond potential
Yeah.
by 50% and another 10% after a year of function. And so whatever you think you're bonding, if you ignore C factor, you should really be cutting it in half. But if you understand the principle of C factor, you can keep that high bond that you initially obtained when you first placed your bond down. Now, every dentist, or the majority of dentists, they think that it doesn't really matter what adhesive you use, it doesn't really matter how you fill it, but if you think of dentistry on the molecular level instead of the macro level,
Yeah.
then you realize how complex that 1 millimeter can be very significant for the size of a polymer, and how it reacts in its configuration. So just restate your question. I think I lost my train of thought. Sorry about that.
No, but it's fine. It's more like, how can we account for C factor when we plan a restoration? What are the mistakes that, for example, people are making that are easy to correct, but actually you just need to change a couple of little bits when you're doing this preparation, and your restoration is then going to be more viable long term?
So the biggest mistake is going fast. As young dentists, we all think, oh, we need to increase our speed. But the problem is the bond takes time to develop. It doesn't matter if you're trying to bond something to a wall or to tile or to a tooth. It takes time for that adhesion to run its course, and that's anywhere between 5 minutes, 30 minutes, or even 24 hours. And it's kind of a exponential curve, and then tails off and plateaus off. So if you can slow down at the very beginning of your preparation, you will give your bond a little bit of a head start that's in the areas that are most difficult to seal and stay bonded long term. And so if you can slow down, especially right after you cure your adhesive, and if you can go do a hygiene check or something like that, that'll improve the longevity of your restoration, quite significantly, just by slowing down at that one particular moment instead of rushing to grab your I think they say in the UK composite.
Yeah. Yeah.
Instead of composite. Then that'll improve the adhesion, because the only real layer that you're really concerned with is the dentin adhesive interface.
Yeah.
So when people worry about, if I layer my composite, I'll have voids in between my composites. Like, well, what will that do to the longevity of, the pulp vitality? Well, we know that composite bacteria between composite is not going to cause pulpal inflammation or pulp death.
No.
So when people get really excited about, a voidless technique, it's kind of like the only void that I'm worried about is if my adhesive delaminates from the tooth. If my adhesive delaminates from the tooth, that means, I made a mistake somewhere, and then, I potentially need to go back in and redo the restoration because it is more prone to leakage and potentially pulpal necrosis.
Necrosis, yeah. I think that makes sense. So what you're kind of saying is that once for example, if I'm using a separate etch, I've done my etching. How long do you etch for?
It just depends on what adhesive you're using. So if you're using a self-etch adhesive, then you wouldn't need to etch the dentin at all. And if you did etch the dentin with a selective etch technique and any of it contaminated the dentin, you would actually lose 50% of your bond strength because the chemistry is it needs the calcium and phosphate crystals that are around the hydroxyapatite. Now, if you're using a total etch system, it's totally different. So total etch system, etch your enamel 30 seconds and your dentin at about 10 to 15 seconds. Just don't over etch if you're going to use a total etch system.
And then, I think that obviously that comes down to one of the really important points. So actually, once in UK, we have something called foundation training, and a guy comes round. He's kind of in charge of the whole group of you, and he came to my surgery when I was in this, and he kind of really made me think, because the first question he asked was what bond and what etch are you using, and I'd never really thought about it before at all. I was just like, oh, I've got some etch and I've got some bond. It's all good.
It's all good. It can be good if you have a good adhesive. Yeah. It can be mediocre if you have a mediocre adhesive. It can be very bad if you got a bad adhesive. So there's a spectrum of bonds, and your mentor had the right question. That's for sure.
But it's really important because actually, maybe they had taught it in university, but the message hadn't got through about really understanding what you're using. And like you say, if you're doing a total etch or a self etch and you're doing it wrong, you could be dropping your bond strength in half. So that's kind of one of the really important kind of messages you probably want to get out. At the moment, I'm doing the kind of the old school gold standard. We have a separate prime, separate bond, and then we go through there.
Perfect. Is that Optibond FL or is it another?
Optibond
So if you have Optibond FL, just stick with Optibond FL. If you got Optibond Solo, I would say switch to Optibond FL. If you got, Scotchbond Universal, I'd say just throw that in the trash.
But I think that's kind of really important, isn't it? Because knowing your etch, knowing your bond, and primer, if you're using primer as well, is so important and key to the long-term kind of aspiration of the tooth. But after you've done that, what you're saying is you want to kind of just bond it and then go off and have a coffee upstairs for 10 minutes, for example.
That would be something that would improve even the best adhesive. So
yeah,
I'd always joke with my old assistant in the Army that I'm going to go take a smoke break, and she knew I didn't smoke, but sometimes I would intentionally slow down and at that critical juncture, and by doing so it helped my dentistry last longer, and that's always the goal.
I think that's so key. Hugh Burns got a question down in the comments. Do you think that a big problem within dentistry is that people aren't using their adhesives and bonds correctly?
I think that's a good question. There are things you can do to make your adhesive dentistry not work as good. Some people use bleach as a disinfectant that can cause problems to the collagen. There are some pre-treatment things like air abrasion that can really help a self-etch adhesive become much stronger as it relates to how thick the smear layer is. And so, I mean, you need to know every step that you're doing intimately to have the predictability that you want from dentistry. And so I would say what's even understood less than people's understanding of their dental adhesives, which is, you know, pretty bad in most instances, really C factor is the make or break, because you can make Optibond FL kind of perform like a dog if you don't understand C factor, and you can make a, you know, a bad adhesive like, you know, anything from 3M SB work better if you really understand how to mitigate C factor stress.
I think in certain systems of work, I'm sure you have some sort of, you know, government-led clinics in the US where it's not, you know, fully private, where you're paid on the volume that goes through the door, which means you have to work quickly, and similar to the NHS in the UK. I think there probably is some sort of an issue there if people are not taking that extra couple of minutes to let the bond mature before cementation. So that's kind of my thought on that. I'm not saying that people are bad clinicians, but maybe good clinicians put into bad situations.
I mean, you can have the right incentives to make even the best clinicians very bad, and, you know, bad clinicians a lot better. It just depends on, you know, the leadership of specific clinics. And when I was in the military, I was lucky that, you know, I didn't have any financial disincentives, but I also, you know, could have easily thrown in the towel and been, you know, okay with work that I would have considered mediocre for, you know, what I wanted to accomplish. And so you've got, I mean, I've got a friend right now in Boise, Idaho. His name is Dave Wold, and he's just in a situation it's like a semi-private clinic, and they've gotten mad at him for taking pictures and, you know, bringing in, you know, some clear fill products that, you know, are much better as far as an adhesive approach than what they were using in the clinic. And it's just like all this red tape for, you know, and vilifying his efforts to improve his level of dentistry. And I just have no respect and no patience for
that kind of place.
for offices that take that approach, because at the end of the day, there is a patient and a living person in your chair. And if you don't take your work personally, you know, the successes and the failures, you know, it's
not great. It's just poorly kind of thought out.
But if you're in like a military situation or you're in an NHS situation, you can feel like your work is totally undervalued, and it's really hard to stay motivated. And I totally get that.
Yeah.
But, you know, sometimes you have to figure out and motivate yourself. Sometimes you do dentistry for you more than you do it for the patient or the clinic. It's like, I'm doing the best that I can for me, not because you even value what I'm doing, but it's like, I need to be able to sleep at night.
Hugh, thank you for joining us. Go and look after your family. Make sure you're following Dave if you're not already. Somebody has a question for you in terms of the adhesive protocol on the day of cementation of an onlay, or what are you doing in that particular situation?
So the most important thing is you need to get access to the unreacted monomers that are in your pre-polymerized, what we call a biobase, or your immediate end sealing. And so you need to air abrade, etch, and then place uncured bond, and then you can cement with like a heated composite is what we prefer.
So you're placing your bond the whole way over the preparation.
Exactly. Yeah. It's kind of like almost like a wetting, a wetting agent to allow the new reaction to occur. And so it's like, even in polymerized composite, there's about 30 to 40% unreacted double bonds that you can get a free radical reaction to start it again if you can,
Yeah.
increase the surface area.
And that kind of process, you're using a heated composite, whatever however you want to pronounce it. Um, and then obviously you're curing. How long are you curing for? Because the curing light is something that's actually very underrated. You can have a great curing light or a really, really terrible one, like something like a velo would be brilliant. But obviously, if the light's about starting to go, you're not going to get the best possible long-term success.
Yeah, it's important to have a radiometer in your office just to kind of intermittently check the strength of your lights. And, I actually did that yesterday in my clinic, and we had one light that was putting out about 680 milliwatts per centimeter squared, and the other one was right around 460. And so 460 is like kind of the minimum that you want. Most lights are, well beyond that, and so, 460 you'll get adequate polymerization and adequate cure. And so, but depending on the intensity of the light, sometimes you have to increase the length that you're curing those indirect restorations with a light cured cement.
Yeah, I think that's really, really key. We've got one more case that you put up, so I know we're just going to switch this around, and this is more in the kind of area of how we plan our actual preparation.
Okay,
So
let's
again,
do
a
it.
really, really beautiful case that you've uploaded onto Instagram. So I'm sure you remember this one here.
Yep.
Let me see if I can get it a little smaller so the guys can see. Come on. There we go. Perfect. So when you're looking at something like this, let's just pretend our Caries dye isn't there at the moment. Are you thinking about the thickness of cusps? Are you measuring that kind of a thing before you decide whether you're going to do a direct restoration versus an indirect restoration? What's your criteria?
So my criteria is based off of a risk assessment that my dad developed. It's 1, 2, 3, 4. One would be any cracks that you see in a marginal ridge, which we'd call a peripheral rim fracture. 2 would be any isthmus that's greater than 2 millimeters. 3, any cusp that's less than 3 millimeters, and then any boxes that are greater than 4 millimeters. And so if any of those criteria are met, we would give the diagnosis that this tooth is structurally compromised and needs something a little bit more
Robust.
Exactly. So it's not going to be just a simple filling. And so you're already going into with the approach that I'm either going to do an indirect restoration, a semi-direct, or a stress-reduced direct with fiber. And this is going to take anywhere between 90 minutes and 2.5 hours, depending on the needs of the tooth. And so I'll always do my initial outline form, and then if I see a tension cusp that has a crack that's undermining, I will preemptively onlay that cusp just so I have better visualization as I dissect a crack or remove caries in that instance. And so I think I was a little more reluctant to do the overlay on the number 7.
Yeah.
But after I saw the amount of cracks that were present and the decay that was undermining those cusps, I elected to reduce those ones as well.
Yeah. And by 4 millimeters in your point number 4, do you mean 4 millimeters of depth or 4
in
millimeters?
depth? Yes. So that we would call that vertical structural compromise instead of horizontal structural compromise. Yeah.
And what's really interesting here is the actual process of the preparation. You've left kind of this buccal segment a little higher. Is that in aid of increasing again the C factor?
Not so much. In both of these preparations, I would consider them, pretty low C factor, and I'm not as worried about the, any additional polymerization stress that would be added. So even if I kept that cusp, when you're just doing a bonded, base like this, the amount of composite material that is adhesively joining the tooth is, the surface area is about 1-to-1, and so it's a very low C factor. So even if that was going to be an inlay preparation, the bonded composite would still be considered in a low C factor situation, but a higher C factor prep. Good question.
And how do you mitigate this by really aggressively looking at the occlusion to see where there may be plunger cusps and the occlusal, the opposite occlusion, to avoid kind of lateral forces where you may be causing too much shear?
Yeah, so I mean, I know there's a lot of people that do a lot of like pre-occlusal assessments before they open up a tooth. That's something I could be better at. As long as I have like 2 millimeters of material, I feel very comfortable that there'll be enough resistance, even in very high force patients.
Yeah.
So
yeah, it's just a question because obviously there are guys who like to do that. I know that we spoke to a lady who trained in New York, and she advocates getting them to chew chewing gum with both her and the nurse marking up the occlusion with 2 Miller's forceps on either side, so you get that really natural. This is how they actually chew, and they can see the occlusal movements. Is really interesting and kind of a novel way of doing things.
Yeah, I've never heard of that. That's actually a pretty good tip.
Yeah, so I obviously there's tips that you can pick up from everyone. I think the guys that picked up a whole bunch from you already. I hope you had your pens and papers ready for the 1, 2, 3, 4 guys. I'll quickly read them back out and make sure we got it right. So number 1, guys, was looking for cracks. And if we see cracks, we're going to look at towards some sort of indirect, semi-indirect restoration. Number 2 was your isthmus, wasn't it?
Yep.
And that was anything that's under 2 millimeters.
Over 2 millimeters.
Over 2 millimeters. And then the cusps were anything which is thinner than 2 mils. And then the box, which is deeper than 4. So
yeah, so the cusp less than 3 millimeters, and depending if it's a holding cusp or tension cusp, you may preserve a cusp less than 3 millimeters. But if you've got a cusp that's less than 3 millimeters, you know that it's not as hydrated as a thicker cusp, and so it takes less force for a crack or a fracture to begin.
Yeah, and you can see that those two restorations there looking really kind of beautiful. There's nothing to complain about there. You can see we've retained so much more tooth structure than if we'd done a standard full coverage crown. And in my experience, when the crowns kind of fail, they tend to fail catastrophically. There's a margin that food can get underneath. That's not something that can happen as easily in adhesive dentistry.
Yeah, the forces of occlusion are concentrated at the bottom 2/3 of the tooth, and so if you can preserve what we call the biorim, which is the 2 to 3 millimeters of enamel above the CEJ, then you've got the tooth's natural defense mechanism that absorbs a lot of that functional and non-functional stress patterns. And so Pascal Magnier in 2002 wrote a very important paper that analyzed this stress with finite elemental analysis, and you can see very clearly, under normal chewing forces where it's concentrated, and that's why at year 7 to 10 you start seeing marginal leakage at the margins of crowns, and in some very unfortunate situations you see them snapping off right at the gum line, and that's just because the tooth and the crown are not moving in a cohesive unit.
Yeah, and this is kind of the thing that I was kind of describing, where this is a crown that I took off, old school dentistry. Food can get underneath there. You can't see.
Yeah, it's a disaster.
It's gone, yeah. And that's a 3-unit bridge, both abutments completely caries the whole way. And we're now looking at overdenture abutments, etc., etc. So, as you can see, this might be a little bit graphic. You can see inside. This is what we had inside the crown. So it's a much cleaner way of doing dentistry, from my point. Got another question down there. How do you cure your composite? Do you use a slow start or a pulse?
I do a combination of both of them. So when I'm doing a large direct composite, I will do a lot of tiny little pulse cures to kind of get to tack them down. So I'll do like 3 or 4 small increments, do a 1 to 3 second tack cure, and then once it's about 1.5 millimeters, then I will go ahead and do either a full cure or a slow start cure where I do 20 seconds and pull the light about 1/2 centimeter or 1 centimeter off the tooth, and then wait 10 seconds and then put the light directly on it. The whole idea of a pulse and a slow start protocol is just to slow the gel point of that polymerization reaction. And if you can do that, you will increase your bond strength probably around 5 to 10%. Some people say that it's unnecessary, but if you can decrease the stress to the point where you get an additional 5 megapascals or 7 megapascals bond in your preparation, then that's nothing but a good thing on a non-retentive prep.
Yeah, and just to confirm, the Pascals is not named after Pascal Mannion.
It's not exactly. It was way before he was even born.
But yeah, it shows that small things, all these little tips and kind of changes that we can do, can add up to a large difference in the end. Yeah.
Correct, and fixing teeth that dentists sometimes think are easy are actually some of the most complex restorations you will be doing for a patient, and every step that you do is the most important step at that time, and so you need to put your focus 100% on what you're doing. You can't, no days off, as they say, right?
Yeah. For the guys who are kind of starting out, what would you say is your biggest tip to anyone kind of wanting to upgrade their level of dentistry, skill up, etc.?
Well, I would say the first thing to do is find something that you're passionate about. If you're passionate about whatever subsect of dentistry, chances are you will become much better at it. And then after you found your passion, then you need to figure out, okay, what's the next step in my progression? Is there a community that has a lot of the same values that I can make some friends that I can bounce some ideas off of? After that, it's probably a good idea to find somebody to train you, so you just feel a little bit more comfortable with the techniques and not just the theory. And then after that, you would want somebody that can mentor you and answer your questions in a very specific manner, in a way that it feels more personalized.
Yeah, I think that's really key. You kind of hit on a really important point. It's very easy for us all to go away and do a whole load of reading, but actually coming down and doing something in practice and doing the actual technical part yourself becomes much more difficult. For example, everybody kind of understands or has a vague idea about how to find an accessory canal MB1, MB2, but actually doing it is so much more difficult.
It's way more difficult, and there's a reason why I'm not an expert in endodontics.
Yeah.
There's a reason why I'm not an expert in periosurgery and all of those things. It's like, I know how hard it is just to do a class 2 right. I don't know if I'm quite ready to become an expert in implantology and some of the complications that you need to be well versed in if you're going to do that, quite regularly.
Yeah, I think that's kind of like the thing, because we can talk about this all day, and I think you're probably the same. You love the subject so much, but if somebody out there who's been watched, so yeah, I've gone and got opted on their film now, and they're just dousing loads of the too much or too little. That's
exactly
the kind of little thing that you need to see actually done in practice, because there is it's more than having the right things, it's then using them correctly as well, and the right timings, the right situational judgment, and when to do things and when not to.
Yeah, I mean, we'd like to think it's all just product based, but at the end of the day, it's like I've got an older brother. He's a world-class artist. He's an expert in watercolor and has become very proficient in oil painting, and that's what he does for his living. It's like, if you're good enough to make a living, selling your painting, it's like you're not just an amateur. And it's like, when I was a kid, I realized that I could have the same paper, the same pencils, the same paintbrushes, and I was never going to be as good as my older brother Joe.
Yeah.
And so what I ended up doing is I quit art. So it's like, to become a master at whatever you do, it's like the commitment level is more than just a product based. You got to put in the work. I'm an avid golfer, and every year you see the guys at the golf course that buy a new set of clubs, and they're still
the same old guy,
the same old guy, and I'm like playing the same irons that I did in high school, which is 20 years ago. And every year I go in with the idea I'm going to buy some new golf clubs, and every year, because I put in a little bit more time, it's like I'm hitting them better than I was, 3 years ago. And so
maybe they lose their golf clubs.
Exactly. I need somebody to steal my golf club so I can have a legitimate excuse to upgrade my equipment.
Don't say that too loud. Someone might actually do it. I think that's kind of the thing. It's all practice, and then you'll start to see the results as long as you're taking the time, the whole slow density, taking the time over it, and getting things done correctly. But yeah, I think thanks for your time, man. I think it's been really, really fun.
Hey, this has been a blast. I'm really glad that we were able to connect, and hopefully it's not too late in England. It's like what, 9 o'clock?
Just about hit 9 p.m.
Just about 9 p.m. So that's not too late. So
yeah.
Anyways, I hope you enjoy the rest of your weekend, and I think you guys are going to be starting up work next week, right?
Yeah, we're still in discussions, I think, about exactly what that's going to look like. At the moment, we're being completely phone-based. Whether we start off just with triage and the worst stuff comes in, that might be the way to go. So we'll have to find out. But it's all very up in the air at the moment. You guys back at work, aren't you?
Yeah, we're back at work. Our state opened up about 3.5 weeks ago, and we were still able to see emergencies if we wanted to. But we've got a couple of English dentists in our upcoming mastership course in June, so we're happy that they're going to be seeing patients in the upcoming weeks. So it's nothing's more frustrating than when you can't do what you love. And so I hope you're able to patients that you're treating. Are you in an NHS system, or are you in private practice, or what's the
we have something called mixed practice. So the majority of my work is NHS based. And then I have some private patients as well that kind of fill in the gaps, and so it's going to be interesting. But I think the main thing at the moment is we have had a lot of cases in the UK, so we need to make sure we're doing things safely. We don't want to be known as that practice that opened up and became a super spreader. Because you'll never get your name back after that, will you?
Well, I think as the data continues to roll out. I mean, I think some of the precautions were okay when we didn't know a lot, and I think now it's time to open things back up and let us.
See how it goes. Yeah.
You got to still live a life with some risk. So, I mean, after this, I'm gonna go and skateboard out behind me. So if I have a broken wrist, that's a distinct possibility, but it's something that I love to do, and if you can't live a life, then it's not a life worth living.
Yeah, sure. So we'll let you catch some wheels. But guys, if you're not already following Davey, make sure you have a look at him, and also his dad's profile, which is tagged in the bio, I believe. So the real OP for all the
Yeah,
stuff.
he's the genius. That's the person you should have been talking to, not me. I'm just the
I didn't kind of see his profile until after I'd asked you. I'm thinking that that I'll have to send
you'll
him
have to reach out, and
yeah.
he'll be very honored if he has the opportunity. So it's been
No,
a
for sure.
tremendous pleasure,
We'll
and
definitely reach out.
enjoy the rest of your day.
Yeah, awesome. Thank you for joining us, man.
Hey, no problem. See you. Bye. Bye.
Bye. Hey guys, thanks for joining me. That's been a double header. First hour with Omid and second hour with Davey. So we've covered quite a lot of kind of bits and pieces today. I hope you've all found that useful, wherever you are kind of in your journey in dentistry. Let me know what you thought, and if you've enjoyed those videos, give the IGTV a screenshot and throw it up on your story, and I'll share that on mine as well if you tag me. So yeah, thanks for joining us. Tomorrow we've got Ida Shah from Harvard Dental School. She's currently a dental student there. We're going to be talking a bit about that kind of environment, what it's like at Harvard, and have a general chat around dental school and how that's going for her as well. So yeah, thanks for joining us. If you had any questions and we didn't manage to answer them, please just drop them in the inboxes, and we'll be happy to get back to you. Okay, awesome. Thank you guys for joining us.